Good afternoon. This is Danielle Chelminsky from the Integrated Care Resource Center, or ICRC. Thank you for joining today's study hall call, D-SNP Performance Monitoring and Oversight, State Experiences and CMS Resources. The study hall call series is supported by the Centers for Medicare and Medicaid Services through the Integrated Care Resource Center. Next slide, please. So before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You can find the login directions in the appointment for today's webinar. To eliminate background noise, phone lines will be muted during today's presentation. You can submit questions via Zoom at any point during the webinar by using the Q&A icon at the bottom of your screen. There'll be no unmuting of the phone lines at the end of the presentation for Q&A, but we encourage you to use the Q&A window since our presenters are eager to answer questions you may have. If we don't get a chance to answer your question on today's webinar, we can follow up with you afterwards. And as usual, we'll be recording this call so you can revisit today's presentation or share the recording with your colleagues who are unable to join. Next slide, please. So today's study hall call will feature 5 speakers: myself, Danielle Chelminsky from ICRC, Jennifer Valentine from the Oregon Health Authority, Patty Killingsworth and Jamie O'Neill from TennCare, and Elizabeth Wood from ICRC. Next slide, please. So today we'll be highlighting state experiences from 3 different states. We will go in order of states with increasing complexity in program integration, from Oregon to Tennessee and then New Jersey. Oregon has D-SNPs, but does not have Medicaid managed long-term services and supports, or LTSS plans. Tennessee has a mix of both D-SNPs and fully integrated dual eligible SNPs, or FIDE SNPs. And New Jersey has all FIDE SNPs. These 3 states will give us an overview of how they've designed and implemented their D-SNP oversight in their state, given their level of program integration. Then I will give an overview of some of the publicly available CMS resources on D-SNP performance that can help states with planning and improving their D-SNP oversight. I will then facilitate a discussion with our state panelists to better understand how they chose to design their oversight programs and to hear some advice for other states that are in the process. Audience members are welcome to pose questions to the panelists as well. Next slide, please. And with that, I'll turn it over to our first presenter, Jennifer Valentine, to tell us about her experience in Oregon.
Thanks. You can go ahead to the next slide. So Oregon began our D-SNP program in 2007. We had 8 initial plans, of which 3 departed, and then we added a new plan 2 years ago. I think there was some challenges initially for some of our plans being so small, and with the additional regulatory oversight that was complicated enough for these plans that they struggled to kind of keep up with everything. So I think that's why we lost 3. And in fact, one of the 3 is still serving duals in another Medicare Advantage plan and is considering rejoining as a D-SNP in the future. So I think it's been an interesting, and now that plans are going to be made permanent or are made permanent, it's a permanent option, I think there's going to be continued interest. So we currently have not a, like say, a small number of our overall population in D-SNPs. We probably have closer to 75,000 full dual eligibles who would be eligible to participate in a D-SNP, and we do not currently have any managed care for long-term services and supports in our CCO side because of a legislative carve-out. So we're still contemplating that down in the future that a way to look at some pilots with integration of long-term services and support would actually be through a FIDE D-SNP. So we continue to look at ways to use this platform to build better integration. We went to establishing coordinated care organizations in 2012 and really have very robust care coordination requirements and things like that, and we've tried to build that alignment into our D-SNP work as well. But when I came on board in 2014 to take this position, we really didn't have any reporting elements in the D-SNPs. I think the original intention of our state agency was that we felt like D-SNPs were super valuable for dual eligibles, that we were just really glad that plans were willing to offer this type of plan. And so I think our agency didn't want to overstress and add additional reporting elements. But then we began to look at how we might build a stronger connection into, like, say, the coordinated care work of our CCOs, and look at the Medicare reporting elements to try to build a platform. So we started with our 2016-2017 contracts, which were, of course, written in 2015. So we kind of really began discussing what would be in this. And in Oregon, we're very collaborative with our plans. So we started meetings to discuss what would be elements. We started with a huge list of all the CCO metrics that we collect and all of the Medicare metrics that our plans are submitting, and tried to start looking at a way to develop a picture. And there's a couple more slides toward the back of the presentation that you can see the actual D-SNP and MA metrics that we chose, as well as the CCO metrics that we did choose. We also added some very narrative reporting elements around things like our notifications process, which is now going to be a D-SNP reporting requirement, but we've kind of been tackling that for several years with a statewide emergency department notification system that is now also going to start moving toward enrolling our SNF, so it would be a pretty robust system here. And then we also collect information about the coordination that's very unique in Oregon about the relationship with the long-term services supports and how that coordination happens through an MOU process, and how the D-SNPs are working within that process for the members with LTSS needs and services. So next slide. So this kind of outlines this slide, just these key elements here. The demographics is one of the areas we just felt like our legislators don't have any idea what is the difference of a D-SNP compared to any other type of plan. They don't know much about Medicare Advantage in general, and certainly not about the D-SNP. So we wanted to start by having population health and general information available. So, what's the difference between our Medicaid population and someone in a D-SNP, and like around the total number of chronic and behavioral health conditions? And when we pull that data annually and we see that we have a significant number that have 10 or more chronic conditions, this tells us a little bit about the complexity of the population being served. We also wanted to stratify for race and ethnicity, gender, and the original reason why someone is entering Medicare eligible. Then our narrative reporting does have a number of things that we require around connections with care coordination. So there's a narrative report that we are reviewing, and then this care coordination notifications, they had to have a policy and then start reporting on the policy implementation, and then this description of the coordination with LTSS, and then these metrics measures. So we really are at the point now where we've just received the first 2 years of reports, and we're kind of pulling them into a single because it was a 2-year contract, into a 2-year report. So I don't have that to share, but when we do, we'd be happy to share kind of the summary report with other states that are interested in seeing how that looks. And then we are continuing as for the 2020 contracts now to look at additional metrics we might choose, additional alignments with our CCO 2.0 process. And I've included some in our additional slides, a link to our CCO 2.0 contracting process, which there's a lot of additional work around in integrated care. We already have integrated behavioral health for several years, but there's some higher expectations going into those contracts. And then we also still use other required reporting that is in the CCO contract around the affiliated Medicare Advantage plan, which will be a requirement in CCO 2.0, but we still do not require a D-SNP specifically. But again, we would like to continue to work toward promoting the D-SNP option and continue to work toward this. I think we're just starting to learn more about these other online resources that ICRC's been sharing with us, and for the first time this year we did look at 2 of our D-SNPs went through audits, and we did take a deeper dive into the audit, but we haven't really had any specific way that audit is, they're accountable for that audit to us. So I'm still trying to work my head around all those kinds of things. So I'll leave it there, and then any questions, but I hope we're hoping to learn more from a lot of other folks who are doing this and feel like we're kind of still at the beginning of where we're going. I think our CCO metrics have been very successful. So by stratifying our CCO metrics by the D-SNP population, we can make some comparisons there. And then looking at the D-SNP particular metrics and the MA metrics, I think has also been beneficial to us, but we're still kind of trying to assess whether we've got the right mix in our reporting.
Great. Thank you very much, Jennifer. Next, I'll turn it over to Patty Killingsworth and Jamie O'Neill to tell us about their experience in Tennessee.
Thank you, Danielle. I appreciate it. And I appreciate everyone joining today. And thank you to CMS and to ICRC for just convening states. It's so great for us to be able to talk with one another and share ideas and information. A little bit of context just about Tennessee and our landscape is that we do have managed long-term services and supports. We now have those programs for all populations, so older adults, adults with physical disabilities, and now for people with intellectual and developmental disabilities as well. So we have for really a number of years been focused on integration and how we bring together physical health and behavioral health, and now long-term services and supports in ways that can really improve the member experience, certainly improve health and quality of life outcomes, and then also more efficiently manage cost. And I think when it became really clear to us that we needed to begin to focus on D-SNPs and on ways to improve coordination and integration of Medicare services is when we really began to look at what was driving a lot of the utilization in our long-term services and supports programs. So if you turn to the next slide, just a little bit of our history with D-SNPs. They really began before we understood how important that coordination was. I think we were our state has some of the earliest D-SNPs that began providing these services. They started in 2006. We began our contracting in 2010, shortly after the Medicare Improvement Act went into effect. But I would say that in the beginning, those contracts were just really very basic. They met the minimum requirements. We weren't being strategic at all about ways to leverage those contracts. And we really weren't thinking about the kinds of policy goals that we might want to achieve at that point. We now have 3 statewide Medicaid managed care organizations, which include the mandatory MLTSS, and they have to offer aligned D-SNPs. That's been a requirement since 2015. At that point, we made a policy choice that we would not contract with any new D-SNPs that were not Medicaid managed care organizations. We really wanted to look towards that alignment to facilitate better coordination and integration of care. We do have 3 sort of legacy unaligned D-SNP contracts that have been around for a number of years now. If we look across sort of the totality of those 3 aligned D-SNPs and those 3 unaligned D-SNPs, we're talking about almost 107,000 enrollees, understanding that those aren't all full benefit dual eligible. So when we track data, we tend to really track it at the full benefit dual eligible level. That to us, those are the people who we really have opportunities to truly integrate and coordinate their care better. Interestingly enough, that 67,000 full benefit dual eligible population as of February 1, 2019 has now increased to 68,000, almost 200. So you can see we continue to increase D-SNP participation on a pretty regular basis. One of those D-SNP contracts, who is a Medicaid managed care organization, obviously does include a fully integrated dual eligible SNP program and what we call a FIDE lookalike SNP. It is a population who's in MLTSS but doesn't quite meet the requirements yet for a fully integrated dual plan because the plan is not yet at risk for the MLTSS services. And because we don't have the institutional benefit in, we're still pretty new in that component of the program. One of the ways that we're really working on increasing enrollment in D-SNPs in those aligned plans is through leveraging default enrollment. I think our plans were some of the first to get approval from CMS to implement default enrollment. Those 3 years represent the years that obviously each plan came in at a different time, but we've seen a fairly substantial increase in D-SNP enrollment since that time, and an even greater increase in enrollment in aligned D-SNPs, which we want to see because we think then we have an opportunity to really coordinate care better to achieve those policy goals that I talked about earlier. If you turn to the next slide, just to give you a sense of how we approach our performance monitoring and reporting, I would say that much like contracting, it really has evolved over time. So if you looked at those early 2010 contracts, you wouldn't see much in there about performance monitoring or reporting. It was we met the minimum standards. We didn't ask them for information. We really didn't get into their business very much. We just kind of let things go. And I think over time, what we've done is to really begin to understand that those contracts can be really effective tools for helping us achieve those goals of improved coordination, improved integration, better member experience, all of those kinds of things. And so we'll kind of run through the different kinds of reports or oversight that we do and the frequency with which those things happen. The first thing is really not so much reporting to us as it is reporting to our Medicaid managed care organization. So we have these 3 unaligned D-SNPs, and it's really important to us that they meet their obligation for coordinating Medicaid benefits, which means that when one of their members has an inpatient admission or an ED visit, we want them to notify the Medicaid MCO, and we want them to work with the Medicaid MCO as it relates to coordination of care. And there are pretty specific requirements in the contract about what that should look like, but those notification processes literally exist with each other. We get some information about that, but the real-time sort of reporting happens amongst those health plans to facilitate coordination processes. We also have what we think of really as being ongoing reporting requirements around encounter data, as well as claim submission files. We're a little bit unique in that we are a managed care state, but we still process our Medicare crossover claims at the Medicaid agency level, as opposed to pushing that down to the health plans. We want to get all of that data electronically. So all of that information comes into us from the D-SNPs, and there are pretty tight timeframes around when we expect to get that, and really high standards around what we expect the quality of that data to look like. The same standards, by the way, that we apply to our Medicaid MCOs. We got a bit of pushback from that in the beginning because our standards were higher than what CMS required, but all of the plans are meeting those expectations. And then we leverage our State Department of Commerce and Insurance to also look at all of the provider agreement templates that the D-SNPs use, any unique provider agreements that they sign, all of their handbooks, all of those sorts of things, to make sure that those documents all align with requirements that we've set out in those MIPA agreements. And if you'll turn to the next slide, I'm going to turn it over to Jamie to talk a little bit more about some of our quarterly and annual reporting requirements.
Great, thank you so much, Patty. So some of the things that we collect on a quarterly basis in regards or from our D-SNP plans is first and foremost our MIPA coordination report. And this has been a great tool for us that we use that really allows us line of sight into how many referrals and how much information is going out and coming in into each D-SNP plan. And so for the MIPA coordination report, it's going to tell us how many inpatient admissions, dispositions, referrals, discharge notifications, hospital stays that they sent to the appropriate plans and how many they received back. And this just allows us to make sure that that coordination continues to happen on a regular basis and that the information is being shared as it needs to be. One of the other things that we get on a quarterly basis is our provider enrollment file. And this file has been really helpful for us to be able to really look at network adequacy across all plans, both aligned and non-aligned. And we're able to take their provider enrollment files and really do a quick comparison to identify where the gaps are in terms of network adequacy, where the biggest opportunities are for a specific specialty type, and where there's the best overlap in terms of being able to have the best coordination or continuity of care across aligned and non-aligned plans. And so we get that file on a quarterly basis, and then we even roll it up a little bit more to do kind of a top 5 of the best overlap across plans, as well as the lowest 5 in terms of the most opportunity. And we share those with the D-SNP plans so that they can use that as a tool in terms of their networking and contracting. Our appeals and grievance reports are reports that we added in 2017 that has been really eye-opening and helpful for us to see the amount and volume, as well as how appeals and grievances are being handled by our D-SNP plans. And what we look for there is really making sure that resolutions and timely notifications, as well as whether they're favorable or withdrawn and the reasons why, to be able to kind of understand what the cause and what those reasons are that individuals within the D-SNPs are either appealing things or filing a grievance. The reports can remain pretty consistent, but one of the things we always look for is just making sure we don't see a big spike or a big drop in numbers. And should we ever see that, those are direct conversations that we're able to have with the plans, because we're able to look at that on a quarterly basis. Our default enrollment is something that we receive specifically just for our aligned plans, and it gives us just a greater line of sight into how that first enrollment or that dual enrollment or that aligned enrollment process works. And so it gives us information around individuals who enroll in their D-SNP outside of the default enrollment process, who opts out and why. Are they opting out prior to the enrollment? Are they opting out within the first 30, 60, 90 days? How are they comparing to the other plans around continuity of care? Are individuals having to switch plans because the plan that they enrolled in did not, have their primary care or specialty provider within their network, and so they had to switch? So we're able to get a lot more detail within this report from the aligned plans to help us understand what that enrollment process in that first 90 days looks like, and how they're able to meet the needs of our D-SNP members across the aligned plan. Next slide. On an annual basis, we do ask our D-SNP plans to send us a copy of their HEDIS and CAPS report, and of course, upon request, we also get their star quality ratings. And this, of course, is great for us to understand any poor performing, icons, as well as any notices of noncompliance or corrective actions that are going to be doing, and it gives us just access to that information. And we also can and do request quality improvement activities based upon opportunities that we've identified that can either help with the quality of care or cost efficiencies from any of the D-SNP plans. All of our reports are subject to audit, and so any report that we receive, as we review it, and if we have further questions or we feel like there's a greater need for us to dive a little bit more into the data or just to get a little bit more specific to understand what's going on, it is subject to an audit. And case in point kind of goes to our next, which is our readmission audit. Based on some of the numbers we were seeing around the MIPA coordination report and the volume of readmissions, had us to say, hey, we want to look a little bit closer into this, and we implemented the readmission audit in 2017. And this has been great to be able to really keep communication and open communication with our D-SNP plans around our expectations around appropriate discharge planning, appropriate contacts and follow-up, as well as education to not only the member, but the family around the care and the things that they need to do to prevent readmission. One of the things that I think has been really, really helpful in this audit is after every audit that we do, we actually have a call with each D-SNP plan individually, and we go through the complete audit tool with them, and we actually go through case by case and record by record and tell them, during this particular review, here's what we identified, here's what we were looking for, and it gives them an opportunity to ask questions, share their best practices, share things that they're putting into place that's going to improve their processes, or even ideas and thoughts about things that they want to do differently that they can collaborate with us on. And then we all get together, all of the D-SNP plans with TennCare, to have joint calls on a quarterly basis. And, you know, of course, the readmission audit is one of those topics that we discussed, that we're able to share those, again, best practices and ideas and thoughts that can be really helpful to the other D-SNP plans. Next slide. I'm actually going to turn it back over to Patty.
Thank you. So we talked about a little bit sort of how our contracts and our monitoring requirements have really evolved over the course of time. I think the implementation of our first fully integrated dual eligible plan presented for us an opportunity to really raise the bar with respect to what we expected in terms of integrated processes. And it also gave us an opportunity to raise the bar in terms of what we expect from a reporting perspective. This is the first time that we actually put contract language in that said the continuation of your ability to operate as a FIDE SNP in the state will depend on your ability to demonstrate the value of the work that you're doing. And so we want to create specific quality outcome measures that you will report on a regular basis and track on a regular basis that will help to sort of make the case that integration really does make a difference, that we really are able to improve the member experience, improve member outcomes. So if you look here, we kind of identified a number of measures, many of which are claims-based kinds of measures. Those seem to be easier, obviously, to be able to track over the course of time, but also some things that are not necessarily claims-based measures, but trying to draw on data that would already be available, that the plan would already be required to collect, but making sure that we're looking at that specifically. As we implemented then the FIDE-like plan for the IDD population, it gave us another opportunity to step back and think about what should those outcome measures look like. Many of the same measures that we are looking at in the other FIDE SNP also applied, but here we wanted to think about employment outcomes. We really wanted to look very closely at behavioral health utilization and importantly at the way that inpatient psychiatric care is utilized in readmissions for that particular type of inpatient setting. But so those are metrics that we are tracking now, and over the course of time, think that we'll be able to make the case that with greater degrees of integration, you really can achieve better outcomes and greater cost efficiencies. I think that, when we talk as states, there's a huge opportunity for us as states to maybe think about coming to some consensus around what could some baseline metrics look like that we all require our D-SNP plans to report, and that we then collect, if we could do that in a standardized way, so that we can begin to make the case that there really is value in alignment. We are currently participating in a study that's being conducted by Vanderbilt University Medical Center and funded by ASPE. There's a few slides about it in the appendix if you want a little bit more detail, but basically what it does is look at our various levels of integration for dual eligibles beginning in 2011 and going through 2016, and kind of looks at it in terms of the least integration or coordination to the greatest. So going from people who are in fee-for-service Medicare all the way up through people who are in a D-SNP plan. In my perfect world, I think this study would have been a little bit later study period when we actually had fully integrated plans that we could look at the data and that would capture more of the time period with which we began really raising the bar and our expectations around the degree of coordination and integration that should be happening among these plans. But nonetheless, I think there'll be some real value that will come out of this, and many of the measures that they're looking at align with these outcome measures that we're requiring our FIDE plan currently to report. But that is something I would love for us to maybe be able to come back to and think about. Is there a way to get to a place where where many of us are collecting the same data, and then one, being able to compare performance, but also being able to make the case for integration on a go-forward basis. So with that, I'll turn it back to you, Danielle.
Great. Thank you very much, Patty and Jamie. Next, I'm going to turn it over to Elizabeth Wood from ICRC to tell us about her experience in New Jersey.
Thank you, Danielle. I, until very recently, oversaw the New Jersey Fully Integrated Dual Eligible Special Needs Plan. I'm with ICRC now, but have only been here for a few months. So I want to share several lessons that I learned in the course of building up the New Jersey oversight infrastructure from a D-SNP in 2012, when the current plan program really started, to the point that it became an all FIDE program by 2016 that incorporated a very robust managed long-term services and support benefit. And in the course of that progression, we just learned so much, like Patty referenced, raising the bar. We learned about where it's most effective to kind of raise the bar. Currently, the New Jersey program serves over 40,000 individuals, and it's an all-voluntary program, so that the people who are enrolled are finding some value in this integrated space, which is exciting. But I should say that today I do not represent the state of New Jersey. These comments are my own, drawn from that experience. So since there's really no manual for states on how to go about setting up an infrastructure for oversight of a D-SNP, I wanted to share some really high-level thoughts with you today about the building blocks or essential elements, kind of like the DNA of setting up an oversight infrastructure that you can just build upon and recombine in different ways to help your particular state achieve its oversight goals, whatever they are and wherever you're starting. The next slide, please. The first really high-level lesson I want to share is that if you're new to this, and this presentation is really aimed toward the beginner, if you're really new to this, it's just important to know that knowing a bit about Medicare is great and knowing Medicaid is helpful, but the dual integration space that you'll be entering when establishing a D-SNP, or even in moving forward with oversight and building up a D-SNP program or progressing toward a fully integrated program, that space is just fundamentally different. It has its own operational and regulatory landscape to learn. And so just be patient with yourself, give yourself time to learn, and don't rush it. Next slide, please. As you're getting started, and once you've entered a MIPA agreement or once you're building upon it, there are more possibilities for oversight attention than there are hours in the day, just as with Medicaid. And it can be tailored to fit your program's needs, preferences, and resources. So wherever you start is good. Starting solely with a self-assessment is a great place to go, because you'll need to identify all of the pieces of your own Medicaid puzzle. Who are the sister agencies touching duals and the D-SNP? What are the different business units that are going to come into play? And then establish what's your baseline, where you're going to get your baseline information. Probably the most important one of those is figuring out, do we have a mechanism or an easy mechanism today to draw down information that tells us where our duals are enrolled? And that's the information that's really going to form the most important cornerstone for any oversight infrastructure you can take from that point, whether it's quality by plan or care management or member rights issues, whatever it is. It all starts with knowing where the member is. So that's sort of well begun is half done from Mary Poppins. So next slide, please. Okay, so once you know what your priorities are, it's really good to reach out to your health plan. So this is just a quick recommendation to get to know your health plans if that's not something that you're already doing as a state. If you don't have a solid relationship with your health plans, then I definitely recommend getting to know them. They'll be thrilled to be at the table, and they have extensive experience with Medicare managed care, and they can really be good teachers to help you with the learning curve on D-SNP oversight. And it can be a little bit uncomfortable as a regulator to establish those relationships because it can feel sometimes a little bit tricky. Like creating those relationships might compromise your own hand in oversight and compliance, but actually it strengthens it because knowledge is power even in this context. Next slide, please. I compiled a little list here of essential resources that I sure wish I had had when I started out. And so certainly not exhaustive. This is a list that covers some good resources. They're official resources, mostly from Medicare, on policy, contracting, quality oversight, and enrollment matters that you may find yourself dipping into frequently. Next slide, please. Once you kind of have a sense of the shape of the program that you're attempting to create, or while you're establishing that sense of the program you want to create through a solid performance monitoring structure, it helps to kind of figure out who your phone a friend friends are. And so this is a list of a regulatory support base that really comes in handy. So beyond your immediate family of state staff and plan staff, I wanted to call out some CMS offices. And sometimes CMS can be a little bit intimidating to approach from the state level, especially if it's a new question. But I just can't say enough about how helpful the partnership has been with the Medicare Medicaid Coordination Office. The folks at the Integrated Care Resource Center are always ready and willing to help you walk through questions that you have. And then one that might not jump out immediately, but is really important, is the CMS Regional Office for Medicare. This office is one that is tasked with overseeing the performance of the health plan from Medicare's perspective, and is really important and involved in overseeing resolution of individual beneficiary matters as well. So a good ally. Next slide. This came up a little bit earlier, but I really want to underline how important it is to place your expectations for performance in the MIPA contract if that's not something that you've already done. And it's something you can build upon as your program evolves. But some states put everything in there, like New Jersey just loads it down like a Christmas tree. It's very, very detailed and extensive. Others place expectations outside of the contract, but however you go about it, just make sure that your expectations are somehow tethered to that MIPA agreement, because it is really unique in Medicare policy for being a vehicle for the state to have standing in Medicare policy and to have its expectations met. So it's a very powerful tool, and we recommend really using it. One note on that, though, is that as of 2021, under some new rules coming out of the Bipartisan Budget Act of 2018 and the CMS final rule of 4185F, there are some new expectations for D-SNPs and the operations and performance therein. So those will affect MIPA contracts going forward. Next slide, please. Okay, this is a quick little graphic of a lot of the functional areas within D-SNP operations, certainly that could be subject to state oversight. In New Jersey, all of these and then some are subject to extensive oversight. New Jersey has a lot of expectations for its health plans in exchange for the MIPA contract and the capitation that goes with it. One item I really want to call your attention to here is that integration, once you really embark upon it, naturally breaks down silos, and it brings some kind of unlikely guests to the table for discussion when you're trying to figure out how to resolve some issue that's affecting care delivery or affecting compliance under the MIPA contract. And so you'll just be reaching out, you'll be on the phone quite a bit in your oversight capacity. So some of this is definitely human to human work. And so especially in the beginning, it's really helpful to map out the parts of the system, your own state system will be affected by your D-SNP program, and identify the junctions within that system. So for example, if a mental health related agency or an aging related agency has to send you a report for you to have good data to share with your health plans, or vice versa, it's really helpful to map out all those junctions, because it's where those little junctions come together that there's the most potential for things to go awry or for compliance issues to come up where your health plans are trying to manage across that great big puzzle that is Medicaid. And so that's just a great first priority place to start if you're wondering kind of where to look for oversight potential. Next slide, please. Okay, so each of these little lessons and building blocks that I've mentioned so far help to create an infrastructure for D-SNP operational awareness, just kind of a general awareness, what's going on in the program, what's the experience of beneficiaries, how are the providers doing. It allows you to check in. That it's just unlikely to exist on its own. So there's some initial build that's going to go along with this to be sure, and I'm sure that the new requirements for MIPA and for D-SNPs going into 2021 are going to certainly put a little more emphasis on the need to build up this infrastructure. So I wanted to share some of the tools, some of the basic foundation of this with you today. The more that a state can do in advance to identify duals in its systems, like I mentioned earlier, through special flags and files or placing language in existing policies and procedures throughout the system, or working with the duals office or working with your health plans to create templates that build in the state's expectations and make review easier. Anything you can do up front that lowers the burden and improves performance at the same time is a great investment to make as you're building up your oversight program. Next slide, please. So you want to build into anything that you're already doing that touches duals, whether it's about behavioral health, aging, chronic disease, you name it. Duals are such a heterogeneous population that they really touch a broad swath of Medicaid operations. And so there's a lot of opportunity to get to know the systems really well. And once those are mapped, to share the knowledge and share the awareness across all of your business units touching a D-SNP, across the business units or state agencies touching duals, and recruit them into the process of oversight. So the more people know, the more they can be thinking about your duals enrolled in D-SNPs, the more they can see in the system who's in a D-SNP should something come up, the more you create this kind of nerve center that assists you with oversight, so you're not always having to do things manually. It's very helpful. And then states can be really concerned about placing too much burden on their contractors, lest they run away screaming, but it's not something to shy away from. If there's something that you just really need, it doesn't exist in a canned form, and most of the reports that are going to exist outside of you're actually constructing it for duals are Medicare or Medicaid specific. And so you're just maybe not going to get the kind of intel you need to draw down from canned reports. But if you create it anew and you work with your health plans to make sure that it's something that is going to be mutually useful and possible, then just give it a nice long lead time so that everybody can set it up in their systems, like good 4 to 6 months at least. And then you can have something that's just going to kind of run in the background and support everyone. And I've found that the health plans often appreciated some of the reports that we did, as long as it was a really collaborative effort. And so the more proactive and collaborative you can be as a state and involving all the partners of this great big matrixed team that goes into creating an integrated care product, the more successful you're going to be in terms of improving performance over time and your confidence in overseeing a program. I certainly didn't know the first thing about duals, D-SNPs, Medicare Advantage when I started all of this. And so it's a big learning curve, but the more you can tap into the entire system supporting it, the more successful you can be. We certainly didn't start out with a really robust oversight program in New Jersey, but now I would say that it's quite ambitious and robust. So with that, I would say for more specific and detailed examples on the New Jersey model, there is an appendix available at the end of the slide deck, and we are working on a forthcoming technical assistance brief to go into more detail. So back to you, Danielle.
Great, thank you so much, Elizabeth. So now I'll quickly go over some of the CMS publicly available resources that states can use to monitor and track D-SNP performance. And we'll also share some links to guides we created to help you access the data in the files that I present and how to easily analyze the data for your state. Next slide, please. So to track overall D-SNP enrollment by plan in each state, you can use the SNP Comprehensive Report. And that report comes out monthly with about a 2-week data lag, and it's useful for getting up-to-date enrollment data and to track enrollment over time, and also to compare your state's enrollment growth to other states and also to the national average. And we have a link at the bottom of the slide, and we'll show some examples of how to use this. Next slide. So here's an example of what the SNP Comprehensive Report looks like if you sort by one state, and we used New Jersey here as an example. And as you can see in the last column, the report lists any FIDE SNP designations as well. Next slide, please. So this is a visual depiction of the number of D-SNPs and D-SNP enrollees over time, comparing Tennessee's D-SNPs as an example to the national average. And this is by using the SNP Comprehensive Report. And by creating graphs like these, states can easily see their growth trends in their state compared to the national average or to compare to other states. Next slide. So another useful report is the monthly enrollment by contract, plan, state, and county report. And that link is at the bottom of the slide as well. And this report shows D-SNP enrollment by contract number, plan, state like the SNP Comprehensive Report, but it also breaks it down even further into enrollment in the county level. And as with the SNP Comprehensive Report, this data comes out monthly and is lagged only by 2 weeks. And this report is useful to states that are looking to identify specific areas of the state with high or low D-SNP enrollment in each plan, and to be able to compare enrollment across counties, across plans, and over time. Next slide, please. And this is an example from the monthly enrollment by contract, plan, state, and county report, just using one D-SNP in Oregon. And as you can see, the graph shows enrollment in this D-SNP by each county as of April 2019. Next slide. So to monitor quality, one useful report is the SNP Healthcare Effectiveness Data and Information, or HEDIS measure report, as Jamie and Patty mentioned earlier. And this report shows how each D-SNP performs in each of the 15 quality measures. And these include measures such as follow-up after hospitalization for mental illness, care for older adults, and plan all-cause readmission. And this report makes it easy for states to look up and track their D-SNP, how their D-SNPs performed in each one of these measures, and to compare D-SNPs to each other, and also to the national average. And we have some examples on the next slide. Next slide, please. So this is an example of one measure, just follow up after hospitalization for mental illness for all D-SNPs in New Jersey, both after 7 days and after 30 days. And the SNP HEDIS file also includes a national rate for each measure, so states can compare how their D-SNPs performed compared to D-SNPs nationwide. Next slide. Another way that states can monitor D-SNP quality is through the Part C and D Medicare star ratings, as Jamie mentioned earlier. And star ratings range from 1 to 5, 5 being the highest score. And we just want to point out that the star rating applies to the entire contract, so not to each plan. And a contract may include enrollment in non-D-SNP plans as well. So just keep in mind that these star ratings may not always apply just to D-SNP. However, the star ratings can be useful for contracts that contain solely D-SNP enrollees. And these measures are useful to identify how plans performed within 5 quality and performance domains for Medicare Part C that are compiled from the CAP survey, Health Outcome Survey, HEDIS, as we discussed on a previous slide, and other Part C and D reporting requirements. And this report shows the overall star rating for the contract, as well as a tab for each individual measure. And the link is at the bottom of the slide, and we have an example on the next slide. Next slide, please. So this slide shows specific star ratings for some example measures, such as SNP care management, diabetes care, members choosing to leave the plan, as well as the overall star rating for the contract. And for this table, we chose contracts that include only D-SNP enrollees. We also included the national average for each measure so states can compare how their D-SNP scored to the average score. Next slide. So there's several other resources and reports that states can use to monitor D-SNP performance, such as the program audit results and any corrective action plans that a D-SNP may have had that Jamie mentioned earlier, and any past performance outlier results. And also in terms of payment, states can track the plan level risk scores per member per month Medicare payments and medical loss ratio data. And if you're interested in these reports, you can see the appendix at the end of the presentation with further details about what's included and links to those reports. Next slide. So if a state is interested in learning more about these or other CMS data resources, ICRC develops 3 data resources guides. And one focuses on the D-SNP plan performance results that I just described. One focuses on publicly available data on the dual eligible population in a state in general, including dual eligible characteristics, service use, spending. And one focuses specifically on how to use the Medicare Star Rating. And these guides also provide some tips on using the Excel files and how to manipulate the data and create graphs and tables to make them easier to understand for decision makers and stakeholders. And additionally, ICRC is available upon request to develop tailored, state-specific profiles on the dual eligible landscape based on specific variables of interest. Next slide. Okay, so now I'm going to pose some questions to our state panelists to hear a little bit more about their process and any advice they can give to other states. And also, if anyone in the audience has any questions, please type some questions in the Q&A box, which you can find by hovering your mouse over the bottom of the screen at any time during the discussion. And also on the line is Jim Verdier, the director of ICRC, who will be joining the discussion. So Patty, Jennifer, Jamie, and Elizabeth, what tips or lessons learned do you have for working with D-SNPs to encourage their cooperation and compliance? And anyone can jump in.
I think it's one of
This is Jennifer. Oh, go ahead, whoever else.
No, that's fine. Go ahead.
Next. So a couple things that we've done is we looked at data that the plans already submit for Medicaid. And what we tried to do is not require a second submission of the same data. So, in fact, we actually bundle data back to the plans for specific reporting metrics. So like if we have collected data from them that we want them to use, we actually pull it specific to their D-SNP members and send it back to them for them to include in their final report to us. So this has gone a long way to sort of ease the path towards reporting, because they were like, well, we already send this to you in this other format for all our members. Why would we send it again separately? And so this was one of the ways that we used to get there. And we also do the stratification on the CCO metrics for those D-SNP plans. So we do that in-house and send that to them.
Great, thank you. And Patty, I think you wanted to jump in?
Yeah, so this is Patty. I think both Jennifer and Jamie kind of talked about this collaborative process with health plans of really engaging with them, you know, helping them understand that we want them to be successful. We want these processes to support their success and helping members have a better experience. So I think that's a way of encouraging their cooperation. I do think at the end of the day, it's also important for health plans to know that you will hold them accountable. And that's one of the challenges of the MIPA agreements is depending on how they're structured, it may be very difficult to sort of leverage them for sanctions and those sorts of things in the way that you might a Medicaid agreement, unless you roll those two agreements together. But it is important for health plans to know that the requirements that are there, that you're going to monitor them, and at the end of the day, you will hold them accountable up to and including no longer having a MIPA agreement with them and not allowing them to continue to operate as a D-SNP in your state. And we've issued those letters before on multiple occasions. You know, if that's sort of the stick that I have, then that's the stick that I will use if all of our other efforts to get to compliance don't work. So it's both. It's both a partnership, but it's also accountability on the back end of that as well.
Great, thank you. And have you gotten any pushback from the plans or anything that you've done to kind of minimize the burden on the plans so that you don't have to use that stick?
I think we've made a number of adjustments to reporting processes. We certainly try to leverage existing data where we can, but we also recognize that there are things that we may want that are not necessarily reported to CMS. And so helping them understand not only why we want that information, but how that information can be useful to them. I think one of the things that we say to all of our health plans, whether Medicaid or Medicare, is when we're asking you to report something, it's generally not just for our benefit. It's also because we think you ought to be looking at it. We think you ought to have processes for using that information. And so the requirement is a way to help ensure that you are looking at that issue, you're gathering that data, and you're taking appropriate actions on it. So again, I think those conversations about process are really helpful. We do a readiness review, not just when we implement a new contract, but with every contract amendment cycle. If there are substantive changes in our expectations, we'll do a readiness review to actually make sure that plans have the systems in place to be able to do whatever it is that we're expecting them to do differently in that as a part of that amendment cycle. Again, I think that's part of helping them understand the value of the reporting and monitoring processes.
Thanks, Elizabeth. And then I would underline everything that Patty just said and share one additional thing that we did in New Jersey. We created a full compliance orientation for all new health plan leaders within the D-SNP so that whenever, and they frequently do have changes in leadership. So we just try to make sure that they understand upfront what the ropes are for compliance, and so that issues aren't coming from guesswork about what we want. That's communicated up front, and they have every opportunity to ask questions, and it nicely establishes that this is an open and collaborative relationship. So to reflect what both Jennifer and Patty have said about how important it is to build out that communication stream with the plans.
Great, yeah, that definitely seems like a theme across all three states. We only have about 2 minutes left, so I just wanted to go around and hear just any high-level recommendations that you would make to other states that are looking to improve their monitoring and oversight, or any kind of final last words of advice.
Well, I know I have a lot of questions left based on Danielle's presentation and like beginning to look at how I can use those other tools that are now going to be available to us through, to help us with that monitoring look and the comparison of plans. I think it's great that it's going to be kind of more accessible to us that way. And so I'm excited to learn, like, for example, will I be able to see some of the data on the quality for not only our D-SNPs, but also our other non-D-SNP plans, because I think that's also, we're trying to promote to leadership that we want to keep moving our platform to potentially all D-SNPs. And we have some D-SNP lookalikes that I think, there was a CMS thing about recently, and we kind of have some same issues that we don't have a lot of control around the monitoring for those plans. But if we could compare how the D-SNPs are doing with those plans, I think that might give us some leverage.
And I would just add that I don't think you just don't have to reinvent the wheel, right? No matter where it is that you're starting, there are a lot of states who are trying to work on the same things, who, you know, they may be at various points along the path, but we can continue to learn from one another in terms of how to move to the next level, if you will, of the monitoring that you want to do and align that with your own policy goals.
Great, thank you both. Can we go to the next slide? Great. Well, thank you all to all of our presenters. A recording of today's webinar and the slides will be uploaded shortly to the ICRC website, and I urge all of you to visit the website where you can find links to past study hall calls, webinars, briefs, and submit TA requests. And we also have a link to some of those guides that we mentioned earlier that Jennifer said that she was interested in, so you should definitely check those out as well. And if there's any other questions that we didn't get to, we'll follow up with you after the presentation. And also, as always, feel free to contact ICRC with any other questions. And make sure to check out all of the additional information in the appendix at the end of the presentation. So thanks again to all of our presenters, our partners at CMS, and to all of you for joining us today. Thank you.